This week on the BackTable podcast.
Patients need, I think, number one, a quarterback and a home base, whatever you want to call it. And I kind of see it at the beginning of their journey. If they have a localized HCC or maybe not HCC, they're still being screened, but certainly not to the point where they need systemic therapy. I feel like hepatology is that home base, and they're kind of the quarterback, and they're saying, all right, CIR, whatever, C surgery. I think once they develop advanced HCC and they're needing systemic therapy, then I think that football, if we're using that analogy, kind of gets transferred over to us, and medical oncology becomes their key point. So I think whoever their kind of quarterback is really is the one who needs to stay on top of everything else that's going on. So, how do we implement that in practice? I think it's challenging because, there are so many other visits, there's so many other patients. And what I don't want to happen is a patient starts seeing oncology and they never see their hepatologist again because, these patients get decompensated cirrhosis and we need help with that, right? We're not, we are trained in internal medicine, but I'm not a hepatologist and I don't want to be a hepatologist. Now, what's the optimal model for that? I don't know. But keeping all these players as part of the team throughout their journey and then making sure someone's the one really coordinating all that, I think is the way to do it.
Welcome to BackTable Tumor Board, your source for the latest on multidisciplinary cancer care. Welcome. Hey guys, I'm Tyler Sandow. I'm an interventional radiologist at Ochsner Health. We're here in the BackTable studio in San Diego, California. I have some of my Ochsner team here with me. To my left, I have Stephen Young. He's a hepatologist with us. To my right is Deondra Bonds-Adams. She's our patient navigator in interventional radiology. And then to her right is John Mizrahi, one of our medical oncologists as well. To break the ice, I just want to do a quick icebreaker question. If you were chicken wing flavor, what would you be?
I have to go with barbecue.
I'm going to keep it classy and go buffalo medium.
Spicy.
Spicy? See, I would be sweet heat. But I've had time to think about this question, so that makes things a little bit easier.
I would have chosen the same for you.
Thanks.
For what it's worth.
I knew you would have. Thanks. On to serious questions. Part of the session today is about patient flow. And I think we get so focused on how our interaction is in the workplace of a multidisciplinary team, but we don't necessarily think about what the patient experience is like. And so I wanted to start off with a simple question and see if you could help guide me this way. Let's say I'm a patient and I just get diagnosed with HCC. What happens next?
So I guess from a hepatology standpoint, a lot of those patients end up seeing us before oncology because they may not call it HCC on imaging, so they'll just get referred to hepatology as a liver mass. And John, correct me if I'm wrong, but we end up seeing a lot of those that just get referred straight to us. And so we'll meet with the patient. I sort of explain how HCC is typically an imaging diagnosis if they already have cirrhosis. And so I'll kind of go through the basics of what treatment options we have, but just about all of our patients we'll discuss in our multidisciplinary conference, which you're a part of, John's a part of, and just talk about basic treatment options first. And then we'll bring them back after and talk about a treatment plan after we've formally reviewed them in our conference.
Okay, so first question, do you routinely ask for biopsies on your patients with HCC?
The vast majority, if they have underlying cirrhosis, the vast majority we can diagnose based on imaging.
Perfect. And I guess my next question, we talk about a multidisciplinary tumor board. Who are the players in the multidisciplinary tumor board?
Yeah, so it's very multidisciplinary. So medical oncology comes, that's my forte, but we're kind of in the background for a lot of these patients because a lot of the ones we're discussing tend to be a little bit earlier stage. So, we have our role. I think radiology and interventional radiology has a crucial role. Hepatology is obviously there, and that's really in our practice, who's, as Stephen mentioned, who's really presenting most of the patients to the multidisciplinary tumor board. Is the hepatologist will almost be the quarterback, the kind of the home team, and they will be, presenting the case and know the background and take it from there. We have transplant surgery. We often have surgical oncology. We have some social workers that are there. I think that kind of runs most of the gamut. I think, a lot of tumor boards will also have radiation oncology. We don't have a huge radiation oncology presence in our tumor board for HCC, but I think that's something that we need to develop a little bit more since there's an increasing role, I think, for radiation oncology in certain cases. And I think those are the main players at our tumor boards.
I will say that we do have a rad onc who calls into all of our conferences. He just never says anything, but in case you ever mention rad onc in any way, he always chimes in and says, "I'm here," just to make sure that we know. So when it comes to treatment strategy, we typically follow the BCLC algorithm, right? And so I would say we break patients into early, intermediate, and advanced stage, and we're going to have a discussion later about advanced stage patients. But early stage patients, I would say, by and large, we're looking at a curative intent approach, right? What do y'all think would determine whether or not we went resection versus bridge to transplant? And this is probably a great question for you, Stephen. What do you look at when you're saying this patient might be a good transplant candidate, this patient might be a good resection candidate, or maybe they might fit for ablation or Y90 as a definitive approach?
So it really depends on their underlying liver disease and where they are in the disease process. So if they don't have cirrhosis, which most people that develop HCC have cirrhosis, but there is a small portion that they don't have cirrhosis. And so those are good candidates for resection. If they have cirrhosis and no portal hypertension, then we also consider those for resection and sometimes ablation if it's a really small HCC. But if they have clinically significant portal hypertension, which we can usually diagnose non-invasively, then those are the patients we should be talking about a bridge to transplant, assuming they have still early stage HCC.
Gotcha. Now, let's say that the patient has significant portal hypertension, and which would obviously dramatically increase their surgical morbidity mortality. But let's say they don't want a transplant, or maybe they're an active drinker. What kind of treatment strategy approach do we go there?
I guess it'll depend on sort of the size of the tumor and the number of tumors. If it's a small single HCC, then we can talk about ablation, potentially a Y90. If it's larger, then probably Y90 TACE would be better options.
Gotcha. So me being the interventional radiologist, and John said this too, and I think you're saying this, we are critical players, and I'm doing this to toot my own horn. I'm doing this as a joke too. But I'm seriously too, interventional radiology does play a key role in the multidisciplinary tumor board. We help coordinate the imaging and then come up with treatment strategies alongside you guys. And we all know, I know how you think and your thought process. And I think we work as a very good unit in terms of how we structure patients, which has probably been one of the big keys to our success is we all have a similar mentality approach. But I do want to get into one of the critical pieces. So we routinely, I would say a lot of these patients will come through interventional radiology. And even though we take responsibility for treating a lot of these patients, we're not necessarily the one who interacts with the patient the most on the interventional radiology side. And I have Deondra with me, and I think it's important to ask her what the patient experience is like. So I guess, Deondra, when you help set up a patient and try to get them established in interventional radiology, how does that interaction go? What kind of things are we looking at? Are we looking to schedule one thing at a time? Are we scheduling a whole box of things? Do we just call them? Do you bring them to clinic? What's the approach?
So the approach is we call the patient to set up a clinic visit to further discuss any interventional radiology treatment. It always starts with a clinic visit. From that clinic visit, the patient will be scheduled for whatever procedure that's appropriate for their treatment, and along with pre-procedure labs. Now, before that happens, most of our patients, we have to get them on the phone to schedule these appointments, and we have to explain that the referral came from their oncologist, hepatologist. It just depends on the referral person, and most of the time, these patients are not aware or don't want to accept the fact that they got this diagnosis, so we have to basically hold their hand through the whole process. We explain that this step is going to basically get you on your treatment process. It's going to help with your treatment plan. And then we get them in clinic. So most of the time when they come to clinic, most of our patients are still in denial. So then we have our fabulous APPs that go through the whole process. We have fabulous schedulers. We get them on the schedule. And from that point, most of our patients are scheduled for follow-up imaging from that procedure. It's usually a month or a couple of weeks, depending on the type of treatment we're trying to establish.
Good. So a couple questions out of that. And what I think is important is that we're not just, what we don't want to be in interventional radiology is a one-stop shop where we're just doing a procedure. We do want to accept some responsibility for the care of the patient. Now, more often than not, our hepatologists and our oncologists spend a lot more time with the patient and have had many more interactions. But we don't want to only be a procedure-focused specialty. We want to take some ownership in terms of when you come into us, we want to treat your problem, but also resolve your problem, or as best we can resolve your problem. So we're scheduling patients for their treatment, but like you said too, we're also looking at labs, and we're also making sure we get follow-up imaging. Now, after that follow-up imaging, what happens do they come back to us?
After the follow-up imaging, they have to come back to our clinic for our APPs to basically give them the results of the follow-up imaging to let them know if the treatment response is working in the right favor of the patient or if they need more treatment based upon what we could see on the MRI. And that all that information comes from the interventional radiologist that performed the procedure.
So we're coming up with a strategy based on the follow-up imaging.
Yes.
Now, I can also understand from a patient perspective that when you get the first hit that you got diagnosed with cancer, it's got to be a shock, right? And so a lot of, like you said before, patients are in denial. They don't want to accept it. What kind of strategies do you use? And I think this is important for all of us to hear. What kind of strategies do you use to make sure that patients don't just go down a rabbit hole or refuse to follow up? Like, is there a lot of encouragement? Is there a lot of follow-up phone calls?
So we have a lot of follow-up phone calls. From my perspective, I try to explain to the patient that this follow-up imaging is the most important part of your treatment process. Like, we need to know if what we did is actually doing this job, basically. Most of our patients don't understand. They just think that it's just an imaging. And I'm like, no, this is going to tell us if that what we treated is actually where it needs to be. If not, then you need to follow up with multiple treatments. I do explain that to patients ahead of time, like this not going to just be basically a one-stop shop. You're going to probably have to come back to interventional radiology for multiple treatments, but it all depends on that first step.
Awesome. Now, I'm not going to keep hammering you with questions, but I do got another one. From a scheduling perspective, what are the barriers to getting patients to a procedure? What kind of things have you encountered when it comes to getting a patient on the schedule?
So most of the time, the barriers are the patient's availability, them having a loved one, friend, or someone that can come with them during a procedure, transportation, depending on where they live. So most of our patients are coming from afar. We have Alabama, Mississippi, Florida. It just depends. And so most of the time, it's the availability and the time frame. And then the next step would be if it has to be scheduled with a certain provider, meaning an interventional radiologist, and what procedure room, meaning like an angio room, a fluoral, or they need to be CT. So that kind of is our barrier, but we know how to work through it.
Oh, I know you do. Now, I'm going to get back to the multiple providers, multiple procedures thing in a little bit. But you mentioned one thing, location. So, and this shifts back to you, Stephen. I think we have an incredible system in New Orleans about how things work. I think centrally our workflow is great. What I don't think people appreciate is the amount of territory that you cover in hepatology, and you as well, John, in oncology. The amount of, like, you cover all of South Louisiana and then spreads into Mississippi and Alabama and parts of Texas. I don't think people appreciate that you are covering such a wide ground. Can you describe, and I think that's also key to your success too, can you describe how what kind of outreach clinics you have and how that works for the health system as a whole?
Sure. So yeah, obviously we're based in New Orleans, so for the most part we're seeing patients in New Orleans. But most of the hepatologists at Ochsner have an outreach clinic. Some are, an hour or two away, so not terribly far. But like Deondra was mentioning, there's still a lot of transportation issues, and people have a hard time getting to New Orleans. So still some of the outreach is sort of local to New Orleans. We have one of our hepatologists who goes up to Shreveport once a month, which for people who are not familiar with, the geography of Louisiana, it's sort of the complete opposite corner of the state. So Shreveport is up northwest state, whereas New Orleans is southeast, so they're about 5 hours away from each other. Personally, I have an outreach clinic in Lafayette that's about 2 hours away, and I think it works well for a lot of patients because when we're talking about the Gulf Coast, we don't have any transplant centers between New Orleans and Houston, so there's really not a lot of hepatology care there. There's obviously gastroenterologists who see a lot of liver patients, but when we're talking about people developing HCC and decompensated cirrhosis, they don't have a lot of specialists to care for them. So I go once a month to Lafayette, which is about 2 hours from New Orleans, 2 to 3 hours from Houston, and see a lot of patients there.
And I think it's big from a geographic standpoint, right? There are large cities in the U.S., and while we are relatively large, we're not that large. Our populace is more spread out across the state. And so when you have a large central populace, there is, you can have multidisciplinary clinic, right? Well, John, you alluded to this earlier. We have a multidisciplinary tumor board in all of the key players are interacting and making good treatment decisions. Now, can you kind of explain, and we do this a little bit with you guys in surgical oncology and medical oncology, what the difference is between a multidisciplinary tumor board is and maybe a multidisciplinary clinic, and how that might affect treatment decisions and outcomes?
Yeah, so a multidisciplinary tumor board would be kind of what I described. We have ours on Tuesday mornings where it's our liver conference, and patients get presented. We're all in the same Zoom or sometimes in the same room increasingly. Well, now it's going back to being in the same room, but a lot of that's transformed into Zoom. So that's, it's great. We discuss patients, but we're not always there. The patient's not in front of us. We're not always there face to face. So a multidisciplinary clinic, on the other hand, is where, a patient comes in and multiple subspecialties are embedded in the same physical location, right? So you have a patient and we would try to schedule them to see multiple, providers on the same day and within the same clinic area. So they might see a surgical oncologist, a radiation oncologist, a medical oncologist, or interventional radiology, all in the same 2 to 3 hour window. And that allows for, I think, a much deeper level of conversations that we're able to have about the patient care, right? So I can have a patient in front of me and walk over to, the surgeon and say, hey, this patient doesn't really pass the eyeball test. They might look good on paper that this was, a transplant candidate or a surgical resection candidate, but I think we're going to have trouble getting them, through a case. So I think it's a different level of really what you're able to provide for the patient. So, I think anytime you can have a multidisciplinary clinic, to me, that's really the optimal pathway for a patient.
Yeah, I agree with you. And I think being able to have those kind of conversations, and even though we don't necessarily share clinic space with y'all, frequently what happens is that our surgical oncologist will come in and they'll be like, hey, I'm seeing this patient in clinic. Can we come talk real quick? And he's like, it looks like a great resection candidate. This patient is not a great resection candidate. And Stephen, y'all do the same thing in transplant as well, right? You share clinic space with the transplant surgeons and the transplant hepatologist.
Correct. Yeah. So whenever we're talking about transplant evaluation, we do what's called Fast Pass, where a patient comes. It's usually a 2-day process where they get all of their testing done. They'll see us, they'll see the transplant surgeons. And so we're working literally in the same rooms, seeing patients. And like John was saying, it's useful because there are some patients that we think may be good transplant candidates, and something's happened in the interim. They were hospitalized and now they're debilitated, or they've had tumor progression or things like that, where we can physically talk and discuss patients right there in clinic.
Yeah, and I will say this, we do a pretty good job of doing this. We don't necessarily have a multidisciplinary clinic with the way we want IR to be. That's something, it's a pipe dream for whenever we can get there. And I realize that a lot of people that will probably be listening to the podcast might be in private practice. They might not be at these large cities or areas where that makes sense. I will say this, and now I'll get to bounce this back to D. Having an IR clinic has been critical for our success, and I don't think people realize the value that brings to patient care. Because before, what would happen is without a clinic, and this was back when we used to have an IR clinic in a closet maybe a decade ago, we would more often than not just accept the procedure and do it, and not really have an interaction with the patient. And my partner, really my boss, Juan Jimenez, made a stride to really set up a clinic. So now we have our own clinic space on the 7th floor of the hospital, where we can see patients, evaluate patients. We run 5 days a week. I think one of the key things though is that we're able to interact with patients. Have you noticed, D, how we might see a patient, we might say this might be a great patient for sedation, or we might plan to do something one way, but then we need to change it and do it a different way based on how the patient, the eyeball test, like John was talking about. But I would say it happens not infrequently, to the point to where it's worth having a clinic. Would you agree?
Yes, it does. Because most of our patients, looking at them physically, they look like they can be an IV sedation case. But when we ask these appropriate questions, are you able to lie flat on your back 45 minutes without readjusting or without any pain? Do you have issues with sleeping at night where you have to wear a CPAP, or you stop breathing at a short period of time that you know of? Have you ever been diagnosed with sleep apnea? That gives us an opportunity to ask those questions versus the patient just coming in. We find out on the procedure table that they should have been an anesthesia case versus an IV sedation case.
I think, too, the importance of having a clinic interaction with patients is we can kind of set expectations, too, right? Like, so I think if a patient comes in and they think they're going to get a procedure, and it may be described as, I'm sure you guys describe us as incredible interventional radiologists, but they may not always think that when they're getting the procedure and they're complaining of a little bit of pain. And by a little bit, sometimes more often than not, it might be a little bit more than a lot. But being able to set the expectation with the patient, hey, it's not just a one procedure, it might be two procedures, or it might be two procedures and a follow-up, or you're going to be uncomfortable for a couple of days after the procedure. You were going to do this imaging after the procedure. I think being able to have those kind of discussions with the patient, also understand where they are in their understanding of their disease process, is very helpful as well.
I might add, just on that note a little bit too, is that, I've worked at centers where patients couldn't tell you who their interventional radiology was, but I find that not to be the case at Ochsner, where, they're like, oh yeah, Dr. Sandow did that case, or Dr. Jimenez, and knowing that who's doing it, they're not just proceduralists, it's a physician who's taking care of you, who cares about your outcome. And I think that actually makes a huge difference. So part of that's the follow-up, part of that's the consultation visit, and part of it's just you guys making sure, the patient knows that they're under your care and you care about them. And I think that goes a long way.
I love it. All right. Now we're doing well on time, so I get the chance to start asking you guys good questions. All right. So hepatologists are the quarterback. John talked about that earlier. All right. So the majority of these patients that get diagnosed with HCC have cirrhosis. Can you talk to me about HCC screening?
Yeah. So typically, anytime you're talking about screening, whether it's cancer or other disease states, you do screening for a disease that's quite prevalent. HCC is pretty rare in the absence of cirrhosis. So the vast majority of our patients that are getting diagnosed with HCC either have cirrhosis, or the other disease process is chronic hepatitis B, where you can develop HCC outside of cirrhosis. So we know that anybody with cirrhosis and chronic hep B should be screened for HCC. So the guidelines by AASLD recommend screening with imaging and AFP every 6 months. So typically that's an ultrasound with AFP, which is a blood test, every 6 months.
Okay, so they get ultrasound and AFP every 6 months. What are your triggers to do anything else? Because obviously ultrasound, it's only as good as the person that's holding the probe.
Yeah, and there can be various reasons why ultrasounds may not give you the best images. If somebody's obese, if they don't have good windows, we may not get good visualization. So if we get that in the ultrasound report, then typically we'll do cross-sectional imaging, either a CT or an MRI. Or if they have an elevated AFP, even if they have a normal ultrasound, that would trigger us to get cross-sectional imaging.
Are there certain etiologies of cirrhosis that are more prone to HCC?
The risk is a little bit different with each cause of cirrhosis, but overall they're fairly similar, somewhere between 2 and 5% probably.
Okay, now I noticed this, and forgive me if this is a stupid question, and I probably am going to sound dumb, but I've recently seen not NASH with an N cirrhosis, but MASH with an M cirrhosis being described. Can you describe that for me?
Yeah, so over the last year or so, we've changed the terminology of NASH, which is non-alcoholic steatohepatitis, or non-alcoholic fatty liver disease. There was some stigma associated with the terms of alcohol and fatty liver, and so we've sort of gotten away from that and described it more as a disease state. So the sort of overall umbrella terminology is MASLD, which is metabolic dysfunction associated steatotic liver disease. So steatotic meaning fat. It's sort of a mouthful. So MASLD is sort of the umbrella term. And then if you have inflammation associated with that, we call it MASH now. So metabolic dysfunction associated steatohepatitis. And then if MASH is there for long enough, you get fibrosis, and then you can potentially end up developing cirrhosis from that.
So it's just a fancy word for fat. And
correct.
That people
more medical.
So it's okay. Well, perfect. So we were still talking about the same thing.
Yeah.
But they also, part of the change in terminology is they wanted to have it incorporate the metabolic disorders that we see associated with it, whereas non-alcoholic did not accomplish that. So now that it's metabolic dysfunction, that insinuates that you not only have fat with it, but you have metabolic comorbidities. So you have hypertension, diabetes, hyperlipidemia, obesity sort of associated with that steatosis.
Perfect. Okay, that makes sense. Now, the Hep C drug probably changed the cirrhotic impact of Hep C, I would say, right? You would agree?
Absolutely.
But what about the incidence of HCC? Because my understanding from this would be that if we fixed one of the leading drivers of HCC, that the incidence of HCC would go down. Is that the case?
For Hep C, probably, but the incidence of HCC is still rising, mainly due to the rising incidence of MASH. It's definitely decreased the number of patients that are developing cirrhosis and decompensations from Hep C. and over time will decrease the risk of, or decrease the incidence of HCC with Hep C. But if patients have already developed cirrhosis from hepatitis C, even treating them, they're still going to be at risk for developing HCC.
And John, we were talking about this. The incidence over the last decade of HCC has increased by how much?
It's about 25% globally.
Yeah.
So the pie, I think, what Stephen's describing is the pie is growing, but how you're dicing up that pie is changing, right? So, and especially in the U.S., right? So Hep B has never been a huge U.S. driver of HCC just because of, it's not as prevalent here, but Hep C has been, right? But that piece of the pie is getting smaller, and MASH and MASLD is really becoming the predominant driver of HCC. But still the incidence is rising. And I think that reflects kind of the rise in MASH and MASLD.
I want to ask some oncology-focused questions. I will say this: at Ochsner, we've built a monster thanks to the success of you guys. But I could imagine that if I'm in a place that's not similar to Ochsner, that maybe patients get diagnosed with HCC maybe by a primary care physician, not necessarily a hepatologist. And so, if a primary care doc diagnoses a patient with HCC, is it fair to say they might see oncology first?
Yeah, I think that happens all the time. I think, historically, Steve might be able to speak to this better than I can, right? Before we even had any effective treatments for HCC, advanced HCC, I think a lot of them were never even going to oncology because there was sorafenib and maybe before that, nothing. But I think now that most people know that we actually have better therapies for advanced HCC, a lot of these folks are coming to oncology first. Not at Ochsner. If it does happen at Ochsner where I'm getting a referral of someone because they didn't go through our typical algorithm and they're coming to me before seeing, Stephen or someone in hepatology, or before seeing, being seen in the IR clinic, I say, whoa, let's make sure we get the group opinion. I want to funnel you back into the middle of that wheel before you see one of the spokes, right? So I think that's super important. But yes, in the community, I don't blame a primary care physician for, not really knowing where to send that patient. So I think from an oncology standpoint, we need to be, on top of what the best treatments are that come way before they ever need to get treated by us. So, if you're treating someone, if you see someone and they're diagnosed with a single 4-centimeter tumor, that's not a patient that needs systemic therapy except for very unusual circumstances. So I think, at our clinic, what I would do is then bring that patient to our liver conference and say, hey, let's discuss this as a team. You also need a hepatologist because you probably have cirrhosis. You need to get evaluated by transplant, by surgery, by IR, and then come up with a game plan. I think in the community, if you don't have that well-developed of a program, then I would advise just having some kind of similar pathway where you can say, all right, if I have this new diagnosed patient, instead of just, putting them on, systemic therapy, saying, all right, where do I send them to get that opinion of what really the optimal treatment is for them? And maybe that's a bigger center, or maybe that's your, interventional radiologist, maybe that's your surgeon or transplant team. But, I think having a pathway for them is crucial. One
of the sort of pros of having an outreach program from us is that I've met a lot of the local gastroenterologists out in the community. A lot of the patients that get diagnosed with liver tumors will end up seeing them and not getting referred to Ochsner up front, mainly for patients that are far away. And so I'm in contact with them. So if they encounter a patient that has HCC, then they'll reach out to me directly, and then we'll sort of funnel them into our tumor board to get the care that they need. So it's not really on the primary care physician sort of knowing all of that, but sort of part of our job as hepatologists is going out to the community, talking about how things are run with HCC and making sure they know how to get patients in contact with us.
Yeah, it's gotten, sorry to keep interrupting you, Tyler, but we've heard you talking a lot. I'm just kidding. So we HCC's gotten incredibly complex, right? That's kind of what we're getting at here. And, I can barely understand it. I hope I can understand it, but, I think for the whole system to understand is not really that realistic. So what ends up happening, and I think what we've developed too is, Stephen will see that patient Lafayette or talk to the patient Lafayette, present them at our liver conference, and maybe the patient does a virtual visit with one of us from medical oncology if they need systemic therapy, if we agree that the patient does. And I might not be the one who ever delivers that systemic immunotherapy to them. I might just say, hey, this is my recommendation, and they go back to their local oncologist, or we set them up with a local oncologist. So I think, we found a way to kind of provide a kind of, HCC expertise without, that patient ever really having to go outside their community.
I think that's really important. I think you're being modest when you say you really don't understand. I think you guys have a complete grasp on this whole thing. And this is not to knock primary care docs. I would just imagine with all the breadth of stuff they have to do, that it makes a lot of sense when you have a patient that gets diagnosed with cancer to see oncology. You guys have set up a monster. And I think that you have connections, you have your fingerprint throughout the South. And what's really impressive with you, John, is that like I know that you do these virtual visits and you set up these treatment strategies that other oncologists will then deliver. And you're doing this just because you want to provide the best care for patients. I'm thinking about this from let's say I'm a private practice IR guy. And let's say that I don't have the same type of tumor board built. I don't necessarily have, or maybe I'm new to a practice and I'm trying to make sure we set up a foothold like this. What would you advise an interventional radiologist or maybe even a young oncologist or a young hepatologist to build this kind of network? What does that thought process or discussion look like?
Yeah, I mean, I think the first is having good lines of communication. Like you say, all right, I know someone who has an interest in doing this. So if you're an interventional radiologist, then you find your medical oncologist, you find your surgeon, someone who like really has a vested interest in saying, all right, we want to provide optimal care for these HCC patients. So whether it's a formal tumor board or whether you feel like I can just phone a friend and say, hey, this is what I'm seeing on the imaging. Let's discuss what we think the optimal treatment would be. Because, I mean, we'll get into this in our later conversations, but we do a lot of combined therapies, right? So, those are particularly complicated. So it's not just they're seeing you doing something and then seeing me and doing something, but sometimes our treatments are ongoing in parallel together. And you need to have that constant communication with one another. So I think if you have an open line of communication and then you can consistently talk as the patient goes along their treatment pathway, I think that's really optimal. But first, finding people who are interested in, providing that best care and then maintaining those communication channels.
I would add to that if you're, out in the community, not at a transplant center, is finding the closest transplant center and being in contact with them. Because especially if you diagnose somebody with early HCC, then a lot of those patients we're considering transplant as part of their treatment plan. And so you want to make sure you plug them in early, especially if they're transplant candidates, because we've seen people that maybe should have gone transplant first and they get resected and then they had portal hypertension. Maybe we didn't know it or maybe it wasn't picked up and, they decompensate after and then they may not be transplant candidates at that point. So sort of identifying your transplant center and being in contact with them when you identify HCC patients.
Yeah, I think at the end of the day, the goal here is to provide the best survival outcome for patients, and transplant is where it sits. Now, granted, there are very few livers to go around, but when you can replace the actual cirrhosis with a non-cirrhotic liver, the patients do dramatically better. Now, I want to hit D again, not hit you, like not actually hit you, but ask you a question. You talked about one of the difficulties, and you do an incredible job at this, so I just want to highlight how you do this. But one of the difficulties to scheduling patients with multiple providers on multiple days at multiple sites can be challenging, and especially for Y90, but all of our stuff. So how do you keep that organized? What do you do?
Take it one day at a time.
Yeah.
So you basically have to see what works well for the patient. Most of our patients, if they're coming from afar, they want to do everything in one day, one trip. So it's just a matter of being in contact with the other providers, try to streamline the scheduling for that patient. If I see they have 2 other appointments, I will try our best to kind of give them at least an hour and a half window for each appointment versus stacking them on top of each other, because sometimes some appointments run over. We want to make sure that it's worked well for the patient and not for us.
And so we are probably, if we haven't done it already, we're going to treat 300 patients with Y90 for the second consecutive year. How do you keep that organized? Right? I mean, because imagine it's a clinic consult. I'm looking at patient encounters. There's a clinic visit, there's a mapping visit, there's a procedure, at least one procedure visit, there's a follow-up, and then whatever happens after that. The ability to make mistakes in that world, and you don't, seems incredibly easy. I think you wouldn't fault anyone for having stuff fall through, but you don't ever have anything drop. How do you make that work?
So as of right now, we basically have what we call like a spreadsheet of all of our patients that are Y90. And so from clinic visit to mapping to delivery and follow-up. So in our Ochsner system, we have in-basket messaging. So we have our APPs, we have our interventional radiologists that are constantly sending messages for follow-ups. Our APPs are on top of it. They always follow up and making sure that we schedule. But as soon as we receive that message, we're calling our patients to get them on the schedule and follow through with it. Most of our patients, they are complicated to get in touch with, but we just keep trying. And one of our ways of if they don't answer, we will send them a letter. And most of our patients have what they call My Chart. They'll see the My Chart message, or we'll contact the emergency contact if we can. Sending a letter has been helping with patients getting back in touch with us. But it's just keep trying. You can't give up, because most of our patients, because they have so many appointments, all of the appointments become one and they're confused. So we are basically the navigator through their whole process.
On this spreadsheet, I want to get back to that. So on this spreadsheet, what's all on it? Is it like, have they been contacted by their provider to let them know that they have HCC, that they, clinic appointment scheduled, mapping scheduled? How does that work?
So that works for basically when they're notified by whatever provider it is that's going to notify them of their diagnosis. That starts. Then the clinic visit is scheduled. That is marked on that spreadsheet. Then we have the mapping date. And from that mapping date is usually between 4 to 6 weeks, depending on the provider that we are scheduling for their delivery. All of that information is on with that patient. I keep my own personal list of people because most of our patients have multiple treatments, so we have to stay on top of it. And most of them need treatment 3 to 4 weeks from the last one. So just keeping a list of all the patients for my own personal use keeps me from having anyone fall through the cracks or don't get scheduled in a timely manner.
No, that's great. But then how do you coordinate it to the provider? So there's probably at least 7 of us that do Y90. How do you make sure that you don't schedule my patient on Wednesday or vice versa?
We have what they call an interventional radiology, like a calendar that has everybody's days when they're working at certain hospitals, if they're off. And I'm in constant communication with y'all all the time. So via text or phone call. And most of the time that schedule changes, but in the midst of that changing, we normally know in advance, so then we can kind of maneuver the patient onto a different day. Now, sometimes y'all don't tell us, so that happens, and then it's a last minute swap-a-rule, but it works.
Now, in the spreadsheet, we're color-coded too, right?
Yes, it's
What
color-coded.
color am I?
I think you're yellow.
Just sweet heat. That's it. I like this. We're rolling back to sweet heat. All right, cool. So I think we're getting close to where we need to wrap up. Now, in the importance of patient care, I think let's look to the future. What do you think can be done to help improve care coordination, or what is the future of HCC going to look like? If you were to try to find a way to optimize what we do, and I think we do a good job, but I think there's always opportunities to improve. What can we do differently? How do we streamline things? How do we make it better?
I think if I had the answer to this, I think we'd already be doing it. I think there's so many moving parts, and the number of moving parts are increasing. And, the stuff y'all are able to do in IR is increasing every day, right? So I think patients need, number one, a quarterback and a home base, whatever you want to call it. And I kind of see it at the beginning of their journey. If they have a localized HCC or maybe not HCC, they're still being screened, but certainly not to the point where they need systemic therapy. I feel like hepatology is that home base, and they're kind of the quarterback, and they're saying, all right, CIR, whatever, C surgery. I think once if they develop advanced HCC and they're needing systemic therapy, then I think that football, if we're using that analogy, kind of gets transferred over to us, and medical oncology becomes their key point. So I think whoever their kind of quarterback is really is the one who needs to stay on top of everything else that's going on. So, how do we implement that in practice? I think it's challenging because, there are so many other visits, there's so many other patients. And what I don't want to happen is a patient starts seeing oncology and they never see their hepatologist again because, these patients get decompensated cirrhosis and we need help with that, right? We are trained in internal medicine, but I'm not a hepatologist and I don't want to be a hepatologist. Now, what's the optimal model for that? I don't know. But keeping all these players as part of the team throughout their journey and then making sure someone's the one really coordinating all that, I think is the way to do it.
And that's when patient navigators come into play, because we're like the behind the scenes person to make sure that all providers are communicating and we're staying on top of a patient care.
I was actually going to mention that having a navigator is key. I think, D obviously helps on the IR side. On the transplant side, we have a nurse coordinator, transplant coordinator, who only takes care of our HCC patients who are undergoing transplant eval. And similar to D, she keeps spreadsheets and is, keeps very organized about when patients need follow-up imaging. If they've been treated by IR and they don't have any residual or recurrent HCC, they still need really close imaging. And so she makes sure that all gets scheduled in a timely fashion. They're seeing us in clinic. I think that's really key to caring for HCC patients. Obviously, we're not perfect at Ochsner. We still have room for improvement. But I would say for centers that don't have a multidisciplinary conference, I think that's really key in caring for these HCC patients. There have been studies that shown that sort of outcomes, dropping off of the wait list, all that is better when you have a multidisciplinary approach to caring for HCC.
So you guys get to brag on your navigators. I get to harass mine in this thing.
Yeah, I think we need more navigators. I mean, honestly, almost like every patient needs their own personal navigator. And, especially because they're cross-disciplinary, right? So Dee's very accessible. I can, message her and harass her, so you don't get to keep her all to yourself, Tyler. But, it's almost like if every patient had their own personal navigator who took them through the process, that would be obviously that's not, I don't know how realistic that is, but, it's having an IR navigator is great, having a hepatology, but almost like you have in transplant where there's someone who's like guiding you through the whole process throughout every specialty is almost, I feel like, the optimal approach, right? So a patient, we get our imaging for advanced HCC at a certain cadence when they're on systemic therapy, and maybe the patient got Y90 while they're on systemic therapy. Y'all get an MRI 1 month after their Y90, and then, I'm like, oh, I want to add a CT chest to that. It's coordinating those like minor details and making sure I'm not getting an MRI a month apart because that's when my cadence was telling me to do it. There are a lot of moving parts here that things can get lost. So I think, in an ideal world, I think having like a single person who would coordinate them on their entire path would be the best. I don't know how achievable.
Well, I
that
love
is.
this. I was actually, as you were saying that, I was thinking, I just took my kids to Disney World, and there's this Disney Genie app, and it literally it describes things and you have your own genie, right? D, you're a genie now.
All right.
You have your own genie that kind of walks you through this whole thing. And so the one thing that can't be echoed enough is that we are successful because our navigators put us in a place to be successful, and they help patients get through the experience. As we end, I thank you guys so much for coming. I'm lucky to be part of this group and just kind of ride on your shoulders because we are successful because y'all are successful and y'all do such a wonderful job. From Stephen Young on hepatology, John Mizrahi in oncology, and Deondra Bonds-Adams in navigating. We're a collaborative group, and it's very fun. So thank you guys. We'll have more sessions throughout the day. I can't wait for you guys to get tougher questions to have to deal with. But with that, thank y'all.
Thank you.
Thanks for having us.
Appreciate it, Tyler.
If you enjoyed this episode, go follow or subscribe to BackTable Tumor Board on Spotify, YouTube, or Apple, where you can watch or listen to the full season covering all things HCC. We brought together leading experts in oncology, interventional radiology, hepatology, and hepatobiliary surgery for discussions that matter and to help you level up at your own HCC tumor board. You can keep waiting for each episode in the season to drop Fridays on the VI show, or you can go follow or subscribe to BackTable Tumor Board and get them all, including the full video discussions and tumor board kits reviews on Spotify and YouTube. Enjoy.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.